Right, I think we can get started. So hello everyone and welcome to the webinar about volunteer responder programs and increasing the survival rate of out of hospital cardiac arrests. Today we will hear why such programs are important, where do they fit within the chain of survival, and how does it look in reality. Our two speakers will cover also how do these systems increase the survival rate. And last but not least, we'll hear the experience of setting up a volunteer responder program in Denmark and what are the challenges associated in its implementation. I'm Alexis Gizekis, project manager at EENA, and I'll be hosting today's webinar. Together with me is David Fredman, co-founder of the Heart Runner system and co-chair of EENA's Tech and Ops Committee, and Mads Gregers, medical doctor in Copenhagen in Denmark. A few words about our speakers. David has a background in clinical science and has an interest in exploring methods to save lives in out-of-hospital cardiac arrest through early intervention. He has been the driving force behind setting up the Swedish National AED Registry, and the topic for his PhD thesis was optimal location for AED installation. Mads has a PhD in out-of-hospital cardiac arrest and volunteer responder programs, and he is currently a board member of the steering committee of the Danish Volunteer Responder Program. So we are almost ready to start. A few notes before I hand over to David. This webinar is being recorded and will be shared together with the slides on the EENA website in the next days. There will be some time for questions and answers at the end of the presentations, but in the meantime, please feel free to write your question either in the Q&A or the chat box, and I will address the questions to the speakers later on. Right, I think we can start, and I will hand over to David now. David?
I'll just unmute, and I hope everyone can hear me. And I also hope that you see my screen.
We can hear you and see your screen, David.
Thank you very much for the opportunity, and thanks for the introduction, Alexis. This is a part of the EENA Knowledge Hub, the Volunteer Responders Increasing Survival Rates of Cardiac Arrest Incidents. And I'm happy to be doing this together with Mads from Copenhagen. These are my conflicts of interests, already been mentioned. I'm a member of the EENA Tech and Ops Committee and the Swedish CPR Council, but I'm also co-founder and operations manager of the Heart Runner system. Out-of-hospital cardiac arrest is a huge healthcare problem in most countries in the Western world. Over 1,000 people every day die from it. Over 340,000 die every year in Europe. And if we were in the airline business, like on this picture, we would not be allowed to leave until we solve the problem. This is a problem of extreme magnitude, but it sort of happens too slowly and a bit out of sight. So maybe that's why it hasn't really been a focus. So I'm happy to be part of this and also to shine a light on things today. Because cardiac arrest is common and lethal, and the dramatic ones, they occur in public. As you see on the picture, this is the Christian Eriksen collapse on the football pitch in the UEFA 2020 game between Finland and Denmark. He was successfully resuscitated, and this specific case has led to the Get Trained, Save Lives initiative, which is going to be launched by the European Resuscitation Council and the UEFA later in November. And I think this also, how unfortunate it however was for Christian and his family and all the team members. This sparked an interest for cardiac arrest all over Europe, I think, and which is great. And I'm really happy to see how well it has been managed, and it really has a spin-off effect which is going to have an impact on survival, I hope. But the majority of the victims in cardiac arrest, they actually die at home. 65 to 80% happen at home, majority are male. In Sweden, the mean age is 71%, so it is older people, but many are actually young. Many are still active in daily labor, so this is not a problem just from dying from age. And international survival rate is less than 10%. Copenhagen, Denmark in all is a great example of how survival can be increased through structured methods over time. But I want to stress that it shouldn't be so low as 10%. Survival is dependent on early CPR and AD use, which is easy to learn, and there are lots of ADs available. So this can be changed. This is the chain of survival, which I think many of you have seen. If you've ever taken a first aid course or CPR course, I think they've shown you this. It was established as early as in the 1990s as a support for education, resuscitation, and also scientific evaluations. And the chain, of course, each link is dependent on the previous. So if a link is weak, then the outcome will be weak. And keep in mind that we have an international survival rate of 10%, and I'll just briefly go through this. The first link is early recognition and call for help. How do you identify someone suffering from a cardiac arrest, and what should you do? Proper identification of the symptoms grants for fast onsets. If you identify someone lying unresponsive on the sidewalk, naturally you should do something. And 2 questions is sort of starting the process at dispatch. Is the person responding, and is he breathing? And the optimal outcome of the 2 questions approach should be no, is not responsive, no, not breathing, go. Start CPR, alert the ambulance, and get the resuscitation going. This is, however, not super simple. It might sound easy, but always start to call 112 if you're unsure of what you're seeing, or if you feel an urge to have assistance, to start the process and get help, because it's never good to be alone in any kind of acute medical situation. More hands on deck are needed, and that's really true in cardiac arrest. The next link is the early CPR to buy time. And CPR, that's the cardiopulmonary resuscitation. Assisted circulation through compressions of the chest to circulate blood, and then you add the rescue breaths to oxygenate the blood. And this prevents brain damage, since you circulate the blood in the organism to prevent brain damage. But it also keeps the heart cells oxygenated to make them receptive to an electrical shock from an AD. And again, I want to stress, learn CPR to be better at it. It's valuable skills and knowledge, but they deprive over time. So you need to keep this fresh and make retrain courses. It's really good. In some European countries, they were trained in hands-only CPR, just push hard and fast on the chest. Or it might be the 30 compressions, 2 rescue breaths, as here in Sweden, where I'm located. Anyway, go take a course and train, because if you know what to do, you will do it faster and you will do it better. But it's also important to keep in mind that if you call 112, they will help you and coach you in CPR. If you're not trained, they will assist you in where to put your hands, how hard you should push, and how fast you should push. So just everything starts with the 112 call. The next step is the early defibrillation to restart the heart. An AD, or an automated external defibrillator, can restore the electrical currents in the heart. But only 2 rhythms are actually receptive for the electrical current. It's the VF, ventricular fibrillation, or the pulseless ventricular tachycardia. And they are present within the first minutes of collapse. So the faster you get an AD on scene, the better. And there are studies showing that you could have a 70% survival if an AD used in the first minutes. But it's also important to understand and remember that keep performing CPR until an AD is present, because the heart cells needs oxygen to be receptive to these electrical shocks. And it's also, even if the VF or the PVT disappears over time, then if you do good CPR, they will be restored and the heart will be, again, receptive for the electrical current from the AD. Because time is crucial, and in cardiac arrest, every minute without CPR or use of an AD reduces the chance of survival by 7 to 10%. This is shown in several studies that we need to act early in the process, as fast as possible. Usually in both in the medical, well, like the ambulance part, or in like in mass cases where you look at the follow-up and the research, you're talking about the witnessed or the unwitnessed cardiac arrest cases. And a witnessed case, that's when you see someone collapsing, and then of course you can act faster. In the unwitnessed cases, it's always hard because you have no idea for how long the patient has been, or the person has been, unattended. And also keep in mind that the majority happens at home, where maybe I'm home alone or just my spouse. So it is a bit tricky to keep them alive. The last link in the chain of survival, that's the post-resuscitation care, to restore quality of life. To treat the reason for cardiac arrest, which mainly is clotted arteries, acute myocardial infarction. So you can go to the cath lab and you can put in a stent, do angioplasty to restore the oxygenation to the heart. And after that, really good with intensive care with induced hypothermia and also induced coma to prevent the brain damage. And this is interesting to see because there are initiatives like we're going to hear Mass talk about how the survival rates actually increase, like in Denmark. And consistent, effective, and sustainable post-cardiac arrest care is important for the survivors and the families. Maybe we will see more individualized care over time as well, because many of the survivors can go back to normal life, which is great. And it's also good that you can understand that it's preventable death, especially when we understand that there are younger cases, even in the 30s, early 40s, dying from cardiac arrest. So the chain of survival: early recognition, call 112 to get help, start CPR to prevent brain damage, get an AD to restart the heart, and then let the ambulance and the hospital take care of the individual. Everything seems simple. This is straightforward, no problem. But this is the actual reality. This is from a publication by Charles Deakin back in 2018. Some 60,000 cases in the UK. 100% of them receive a 112 call, but only 48% actually receive CPR while waiting for the ambulance. And only 11% are defibrillated, and that's the 11% that receive the post-resuscitation care. And this was an eye-opener for me, and I believe for many. It's vital to keep the patients in, as many patients as possible in each link of the chain of survival. Otherwise, it's not going to function. So it's not only the strength of each link, it's the number of patients that you keep in them. To start CPR prompted by the dispatch, or maybe I know what to do, and also to get an AD on scene, so we actually have possibility to restore the circulation. That's going to leave us with more patients to be transported to hospital by the ambulance. Because if you remember this one, survival chances decrease by 7 to 10%. The mean ambulance time in Sweden is 30 minutes in the high priority calls, from call to arrival. That leaves us with negative 30% survival chance. I believe it's the same thing in maybe Denmark, which is a smaller country, is more densely populated. I believe that the figures aren't super different. But this can change, and this must change. And the European Resuscitation Council stated in the 2021 CPR guidelines that they listed 5 top messages for system saving lives. And this is what we're doing here today, to raise awareness about CPR and defibrillation, to train as many citizens as possible, and to engage like in the yearly Restart the Heart Day, which is 3 weeks, was it the 16th of October, and to develop new and innovative systems and policies that will save lives, like the UEFA ERC collaboration about training people associated with the football community, but also to use technology to engage communities, which is the topic for this webinar, to implement technologies to alert volunteer responders in cardiac arrest through smartphones, to increase the chance that someone actually is close and perform CPR. Just want to give you a bit of a background. A long time ago, in a land far away, and that land being Sweden, an idea was born, and this was before the smartphones and GPS technology in every device as today. What if it's possible to alert motivated and educated volunteers, to actually have them respond to a cardiac arrest nearby? And this idea was born from a dire need when a physician was sitting on a bus and it wasn't leaving the bus stop for no obvious reasons. And when it actually eventually raced off after 15 minutes, an ambulance stopped behind, and there was a lady suffering from a cardiac arrest in that bus stop. And later, this physician learned that he was 3 meters from a cardiac arrest, reading the newspaper, not aware of that his help was needed. And the lady didn't make it. Many thought that this was crazy because smartphones weren't available and the cell phones weren't really that well spread. And how should you do this? But research proved that benefits and that perseverance paid off. And this is a publication from 2015, and I'm proud to be a co-publisher of this, where we actually showed that alerting volunteer responders over a distance which was not more than 500 meters actually could increase early CPR by 30%. And after that, several publications have come out. Multiple publications from many countries about notifying citizens in cardiac arrest using different technologies, different approaches, different distances, different number of volunteers alerted in each case. So things are really taking off here. And in July this year, a publication with over 9,500 patients from 5 European countries proved a dramatically increase in 30-day survival when volunteers were alerted and first on scene in cardiac arrest. So this is pooled data from different systems in the Europe. And if you're interested in this, there will be links to any of the publications and what's been sent out afterwards. Actually, 30% increase in CPR and dramatically 89% increased defibrillation rates. But most interesting, I think, that's a 22% 30-day survival. So keep in mind from the first slides, there is an international 10% survival in cardiac arrest, and it was increased to 22%. This is massive. And when it comes to volunteer responder system, an estimation is that 50% of the countries in Europe have a system at some level, might be regional, might be in just a few regions or parts of a region, but they are alerting volunteers at some level. And generally, they rely on the same idea to alert volunteers to increase engagement and survival in cardiac arrest. Sometimes it's educated and well-equipped volunteers, and sometimes it's lay responders. And Denmark is, to my knowledge, the first European country to have a national unified system alerting volunteers responders as early as in 2020. And it has been a great success, and that's why I'm really proud to have Mads here presenting and speaking. So Mads, the floor is yours, and you just tell me and I will switch slides.
Yeah, thanks. Next slide, please. So thank you for inviting me for this webinar. And my name is Mads. I'm a medical doctor, currently working in anesthesia, and I have a PhD in out-of-hospital cardiac arrest from the Emergency Medical Services in the capital region of Denmark, where I've been a part of the Danish Volunteer Responder Program. And I have a slight conflict of interest as I'm also a medical expert for ONO medical who's developing a small AED. Next slide, David. So in Denmark, for the last 20-25 years, we have worked a lot with improving survival in out-of-hospital cardiac arrest. And there's been a lot of steps before we implemented the volunteer responder program, first in 2017 and later national in 2020. It all started in the zeros, where it was by law mandated that CPR training and AD training was implemented in primary schools, which later also was what is called, it was required when you were obtaining a driver's license. And later we established the national AD network, and that was basically the first step of the journey to implement a volunteer responder program. And before the volunteer responder program was implemented, the dispatch center, they started to call owners of nearby AEDs in order to bring an AED to a patient in out-of-hospital cardiac arrest. And if we look at this timeline, we can see that some of the steps also are directly linked to an increase in both the proportion of patients who receive CPR and that are also defibrillated by an AD, but also survival here in Denmark as well. For the last 5 years, we've worked intensely with implementing the volunteer responder program. And as David mentioned, we were the first country in the world to have one single system implemented in all regions and on a national level. And that's been quite challenging, but also very important for us to hopefully increase survival. Some of the next projects we've been working on have been equipping drones with AEDs, and they've also done this in Sweden. And actually, the first patient have been successfully resuscitated in Sweden a year ago, approximately. Next slide, David. And I'm sorry for this text being in Danish, but if we look at the orange curve, we see that that's the proportion of patients that receive help or bystander CPR from random bystanders. And if we look at the timeline, we see around 2011, there was a high increase in the proportion of patients receiving bystander CPR. And that was the time where we introduced healthcare staff at the emergency dispatch centers, and where we began to also instruct bystanders by telephone via the medical dispatchers to perform CPR. So that's one big step here. The green curve is the use of publicly available AEDs in public spaces, and now we see that around 25% are defibrillated by an AED. However, if we look in private homes, the number is still quite small, but it has increased from below 10% to around 10 to 15% at the moment. And also the red curve is the proportion of patient that survives an out-of-hospital cardiac arrest, and it's been up to around 16%, but it's kind of stayed in that area for the last couple of years. So perhaps we found a plateau at the moment, but we don't think that we're there yet, as we know that early bystander defibrillation is very crucial for survival. So on the next slide, I'm just going to show you a small video that's like a concept video of the Danish volunteer responder program, and also that video has been used on national television and in cinemas in order to recruit volunteer responders.
Vagtcentralen, det er sygeplejerske Annette. Hvad er der sket?
Jeg skal have en ambulance. Jeg tror, min mand er ude af hjertestop.
Jeg sender hjælpen ud til jer. Den kommer hurtigt. Der er en ambulance på vej, og der kommer også hjerteløber ud til jer. Der kan se, at ambulancen er hastigt på vej til jer. Den kommer inden for få minutter, ikke også? Der er noget hovedgård.
kommer muligvis nogen og banker på døren. En hjerteløber. Der er nogen med døren, der er ude og åbne for dem. Det er ham med hjertestarteren. Han er i gang.
Thanks, David. Next slide. So as we see in the end of this video, we saw that around 4 out of 10 reaches the scene before the ambulance. And that was from the first year of implementation in the capital region, which is a very dense region where we have very short ambulance response times. And after we've implemented on a national level, we've actually seen those numbers. They've gone up to around in 60% of all cases, a volunteer responder arrives before the ambulance, but that's just a small detail. So just to summarize how the system works, whenever the 112 dispatch center or the emergency medical dispatch center, they recognize an out-of-hospital cardiac arrest, or at least they think that this case could be a cardiac arrest, they are able to alert the volunteer responders just by clicking on a button in the dispatch manual dispatch program that they use to also dispatch ambulances. And the program, the volunteer responder program, we use the heart runner system in Denmark. It will automatically locate the 20 nearest volunteer responders within a 5,000 meter radius. And they will receive an alarm on their smartphone, as we just watched. And the majority of those who accept the alarm will be guided via an AED, which is mapped on the screen as well. And the volunteer responder program is linked with our national AED register, which holds around 25,000 AEDs publicly available all around Denmark. And they will be guided via this AED in order to bring it to the patient to increase defibrillation. So if we look at the numbers, it's 80% of those who accept the alarm, they will be guided via an AED. So if all 20 accept the alarm, 16 will be guided via an AED, and the last 20% or 4 persons will be sent directly to the scene in order to assist with CPR. And we've chosen to do this because we know that it's early defibrillation that are very important, and the 112 dispatch center, they will always guide the caller to perform telephone guided CPR, and they also have the opportunity to live stream from the caller's mobile phone to watch what they are doing, so they can better instruct the caller to perform CPR. So we know that someone is already performing CPR or should be performing CPR at scene. So that's why we've prioritized to get an AED out there as fast as possible. Next slide, David. So in Denmark, currently we have more than 150,000 registered volunteer responders. And if we look at that per 100,000 inhabitants, it's more than 2,500 volunteer responders per 100,000 inhabitants. And those numbers are also very high, and probably probably the highest density of volunteer responders in the world. And with our system, we've chosen not to distinguish between whether you're a healthcare professional or medical trained in any way. So it doesn't require any prior CPR training to register as a volunteer responder. But we see that the vast majority, they report that they have received CPR training before registering as a volunteer responder. You just need to be above 18 years of age, so you need to have a legal age before you can register. But otherwise, there's no, you don't need to be trained in any way. And the average volunteer responder in Denmark is around 37 years of age. So it's primarily the younger ones that register, but we also have some more elderly volunteer responders that register, and also they still accept the alarms. So that's just fantastic. And it's 50-50 male and female ratio. And if we look at the curve on the graph here, that's just to show the increase in in number of registered volunteer responders. And of course, it's difficult to recruit more than 150,000 volunteer responders. Next slide, David. Next, yeah. But we have been so lucky that we've partnered up with the Danish foundation, the Trygfonden or Tryg Foundation, which is a huge foundation that's it's basically also an insurance company, and they use a lot of their profit to do things like this, like these national initiatives. And this is a commercial from in Copenhagen, where they've actually painted some houses, and it says that we should help each others save a life when there's a cardiac arrest, so sign up as a volunteer responder. You also saw the first video. That's just one of many, and the Trygfonden has produced a lot of videos that's been run on the national television, in cinemas and in buses and train stations, basically everywhere. So it's very important to have someone that can help you with recruiting of volunteer responders, and I think that's a part of the success that we've seen here in Denmark, and that's what some other programs they are lacking. They need money, and they need someone that can help to recruit the volunteer responders. And it's also important to nurse those volunteer responders, because they are very keen to attend incidents, even though that we know that we have an over triage of around, it's only around 60% of our cases that are actually true out of hospital cardiac arrest, but they are still very keen to accept the alarms and attend the cases.
Yeah. Let's just ask a question about, now you say that the over triage and that 60% are like proper cardiac arrest. Would you like to elaborate a bit on that? What's the difference between the suspected cardiac arrest and the ones that are sort of treated by the ambulance as a cardiac arrest?
Yeah, I mean, of course, there will always be, and I think a system like this should have over triage, because in that way, hopefully, we don't oversee so many true out of hospital cardiac arrest. But those that are not, and we have actually have a PhD student ongoing at the moment that are trying to look into who are these not cardiac arrest cases. What is it that they end up? Do they even get admitted to hospital, and what are their discharge diagnosis and so on? So basically, we don't know so much about those remaining 40%. But of course, it's like it could be the drunk guy, be after partying or something like that, that are perhaps a bit unconscious, and when the ambulance arrives, it's not a real cardiac arrest. So it's, but at the moment, actually, we don't know much about those remaining 40%. We haven't done any research yet showing which diagnose will they get. But of course, there's a proportion of those types of patients, and there's also, you could say that the one that's are obviously dead, they will not end up in the cardiac arrest register as well, but they could receive a volunteer responder activation as well. Yeah, but that's more technical, I guess.
Because it's also, it's a very challenging situation to answer the 112 calls of dispatch, and understanding what information is given by this stressed individual for the first time, placing a call to 112 and maybe seeing their loved one unconscious on the floor. How to get the right questions asked. This is what's creating the over triage. You need to be sure to include as many as possible to not miss the non-obvious ones.
Yeah, and I guess that's also in line with the no-go guideline. You want to make a fast decision, so you send out some volunteer responders and some ambulances, and there will always be over triage in a system like this. That's for sure, and that's not only cardiac arrest. That's also stroke and a lot of other things. Acute myocardial infarction. That's also a classic one. Yeah. All right. Next slide, David. Yeah, so how to implement a volunteer responder system, and basically, David, you're probably the right one to also to talk about this. But there's a lot of stakeholders that needs to come together and decide what to do. And in Denmark, it's been quite I don't know, it's not been easy, but we've had the pleasure of the Tryg Foundation, which is again a lifesaver. They've spent so many money on this project, and also they've also the owner of the AD register, and they do a lot of other things. They've distributed I don't know how many AEDs out in the society. So partnering up with someone like Trygfonden, it could be anyone that are interested in saving lives, basically. But it's always difficult with budgets and so on, and especially in the healthcare system, and that's not different in Denmark. But they have for sure been a driving force. And of course, you need to also engage with the emergency medical services in the local areas. In Denmark, I think we're quite lucky in Denmark because Denmark is a very small country, but we still have 5 different regions with their own dispatch center. But it's still only 5 dispatch centers. So basically, it's 5 directors that needs to sit together and decide something, and that's why this was possible to introduce on a national level in Denmark. Hopefully within the next 2 years, the Tryg Fund will hand over the program to the Danish regions, and it will become a fully publicly funded. So that's been decided, and it's in process at the moment. But it's been a very exciting journey. I don't know, David, if you have a few words to attach to this as well.
Just like you mentioned, it's the identifying the right stakeholders, because it's going to be really hard to bring something like this to, even on a regional level, without access to the dispatch organization and without support from healthcare, be it the EMS or if it's going to be the hospitals. So if the right people aren't collaborating and communicating, I think it's going to be really, really hard. So if you're looking at setting a system up for alerting volunteers, find someone to collaborate, and that so you understand that you share a common ground. You need to identify the magnitude of the problem of cardiac arrest in your country, and have the right people understand that. And if you could find a financing partner, I believe that the Trygfonden, they are unique in Europe, but there are similarities. It could be insurance companies, it could be someone else, the Heart and Lung Foundation, or someone sitting on some kind of money to make the first crucial steps happen. But you need to identify the problem and realize it to the right people. And I think that one great thing from my perspective is also, it's not only saving lives in cardiac arrest, it also strengthens the community. Like I believe that the film that you showed, that is a real cardiac arrest call, isn't it?
Yeah, I think so. Yeah, it is. Yeah.
Well. And the fact that someone is arriving to relieve the caller from performing CPR on the loved one, I think that's great. Even if not survival always is the outcome, it's relieving the stress, and you can start with managing your own crisis. And I think this is something that has been really well communicated in Denmark and as well in Sweden and many other European countries, even though I don't grasp the full picture. but the feeling of safety that actually a citizen will respond to this cardiac arrest and be part of the resuscitation process. I think it's great.
Yeah.
Should we go to the next slide?
Yeah, next slide, please. Okay, so if we look at volunteer responder programs throughout the world, there are several programs out there. In Denmark and Sweden, we use the Hardrunner platform, but there's also the GoodSam application used in UK and in Australia and New Zealand. And the Pulse Point primarily used in United States and in Canada. But what we see is there's a huge difference in how we do it. In Denmark, we alert 20 within 5,000 meters. In Sweden, our close neighbor, where they have the same program, they alert 30 within 10,000 meters. In United States, they alert everyone within 400 meters. In Australia, 3 people, or at least in the Melbourne area, they alert three people within 300 meters. So it's very different out there, and currently there's no good consensus on which numbers is the right to alert and what distance should we alert within. And there's probably also a question about geography and demography and a lot of other things to take into account when you set up your system. But at least for the moment, there's no true consensus on which numbers should we look at, and that's quite interesting. And we've looked at some of the numbers, and I'll present it in just a slide or two.
Yeah, and I think you're mentioning this, there is no consensus, but you and I, we met at a consensus conference a year ago, where several system providers, but also researchers tried to collaborate on data points, what to report. If you're reporting science using a system that alerts volunteers, how should you have uniform reporting so that we actually can compare apples and apples, compares. So things are moving in the right direction, which it's great.
It is, yeah, and that's the way it should be done. But it's a process. It takes some time.
It is, yeah. Next slide.
Yes, please. So these are the results from the first year of the implementation of the volunteer responder program by Trygfonden in the capital region of Denmark, and those results are published in Journal of American College of Cardiology. And we saw that around 50% of those who gets an alarm, they also either accept or reject the alarm. So half of them, they never realized that they got the alarm. Their telephone was in the bathroom, in the jacket, in the hallway or whatever. And out of those 50% that sees the alarm, around 50% again accepts the alarm. So around 25%, and those numbers have actually increased to around 30%. They end up accepting the alarm out of the 20 volunteer responders. And in this study from the capital region only, we saw that around 40% of the cases, a volunteer responder arrived there before the ambulance. But when we include the more rural regions in Denmark, the capital region is again the most densely populated region with not so much rural space. But if we include some of the other regions, we see that these numbers, they have increased to around 60% of the cases. And of course, those areas, they have a longer ambulance response time. And if the ambulance response time is long, there's more time for volunteer responders to arrive there and do something good. So that makes quite sense. But what is probably most important is that we see that bystander defibrillation rate triples when a volunteer responder arrives there before the ambulance. So that's very, very interesting. This study was a registered study and not powered to look at survival in any terms.
And I'd like to point out that in Denmark, you have a tremendous leap ahead of many other European countries, since you have lots and lots of AEDs available 24/7 in cabinets available outside buildings. That's not the case in Sweden, and I don't think that's the case yet in many European countries. So congratulations to that. And that's also something that the Tryggfonden has been the driving force behind. And that's really a key factor here.
Yeah, and that was, as I mentioned in the beginning, that was basically the first step of implementing the volunteer responder program in Denmark. That was in around 2010, where the AD register was implemented and launched. So it's taken a lot of years before we started the volunteer responder program to get the AD program up and running, and to get a lot of ADs registered in there. And and currently we have more than around 25,000 registered AEDs. So that's also that's very impressive, and that's also been driven by the Tryg Foundation. And next slide, David. Yeah, so we talked a lot about how many should we dispatch to the scene in case of a cardiac arrest, and we saw that when we look throughout the world, there's a lot of different ways to do this. In Denmark, we alert the 20 nearest. So I thought it could be fun to look at, does it matter whether 1, 2, or 3 or more volunteer responders, they show up on scene before the ambulance? And what we saw was basically that it doesn't matter with regards to how many receive bystander CPR. So when just at least one volunteer responder arrives on scene, there will be an increase in bystander CPR, but it doesn't increase more when 3 or more arrives there, and that makes kind of sense, because you just need 1 to show up to start CPR if it wasn't started before their arrival. But when we look at bystander defibrillation, that's the bottom one over here, we see that when 3 or more volunteer responders arrive before the ambulance, bystander, the odds ratio of bystander defibrillation is almost 4. So the proportion of patients that are defibrillated by an AD is associated with the number of volunteer responders that arrived there before the ambulance. And I think that that's a call for action for that. We should at least ensure that we have enough volunteer responders that accept the alarm, that are close by and can bring an AD. And I think if we only alert 3 volunteer responders, that's probably not enough. But of course, there's always room for discussion with respect to geography and demography and how you want to set up your system. But I think it's, at least in a Danish setting, I think it's reasonable that we continue to alert the 20 nearest volunteer responders. Next slide, David. So how about survival? Well, we saw the paper that David presented, and I think that everyone believes that volunteer responder programs, they increase survival, but we need some good randomized clinical studies before we can say anything for sure. It's primarily register-based studies out there that are based on very few numbers. So we can't say anything for sure without bias and confounding. But in the capital region of Denmark, we are actually randomizing patients to receive a volunteer responder response or not. And we've been doing that for some years now, and hopefully we have enough patients to cancel the study, hopefully in the end of next year. So at the moment, when the dispatch center, they activate the volunteer responder system in the capital region, it will either send out an alarm or not, and it's a computer that randomizes this process. So we hopefully will end up with 2 similar groups where we see that there's a survival benefit of receiving a volunteer responder response. But we'll have to wait a bit longer before we get the results.
Yeah, but it's not an argument if it's saving lives. I believe always a value with having randomized controlled trials, because I have a background in science, and I think that's evaluation of any kind of system like this. It's really important. But we know that it increases bystander CPR, and the earlier you get it, that's not the dispute. The more people who receive CPR, the more survivors we will have in cardiac arrest. But I really admire the Danish approach to perform a randomized controlled trial. It's great. It's also great to be part of it.
I think that was my final slide. Perhaps there's one more, David, from the conference we just touched base on before.
Yeah, because like Mads mentioned, there is an ongoing process with trying to align the data reporting points, so that researchers are comparing similar measures to understand the outcome, which is really great. But also a proposal to increase the safety of the volunteers. That a system alerting volunteers, there should be a possibility to have a callback functionality, so you don't end up in a situation which is unfit for you. So there should always be a way of pulling the alarm back, and also updating it to give more information, so that you actually can enter the building if you need a door code or something like that, and to give good understanding, and also all the kind of incentives to the volunteers that you are a volunteer. You're not required to respond. You can always discard the alert, because this is also an interesting to be part of from a scientific and technological standpoint, that this is a great idea, but it's going to be evolving. So it's great to be also together with you, Mads, and many other clever people, trying to find the good reporting points so we can compare it and see the outcome, but also taking care of the volunteers, because everything is in the benefit for the person suffering the cardiac arrest, but the volunteers, we need to take care of them as well. So it's good. I know that there is a publication coming out soon. I met some of the researchers just last week, so it's coming. And I guess that's the last slide. Thank you very much, Mads, and thank you, EENA and Alexis, for letting us have this. And I guess the floor is open for any questions.
Yes, thank you, David and Mads. It was really great presentation. And I think it offers a lot of key points on how volunteer responder programs can work. We have some questions in the chat. If there are any more, I'll ask the participants to write them either in the chat or the Q&A panels. First question is about the video that we watched, and if it is publicly available, and if so, where?
Yeah, it is publicly available, and it can be found on YouTube. And I think I can present Amy with a link to the video, so it can be a part of the material that will come out after this meeting, so everyone can watch it.
Great.
Perfect. There is another question. There are also many positive comments, and there is a question: do you share experiences and lessons learned with other countries and regions with similar volunteer programs?
Yeah, as David mentioned, we have this conference where we meet, and we were in Germany last year in the spring. A consensus meeting. So that was basically experts from all around, primarily Europe, having different responder programs, both on a national level and regional level. And yeah, so we do meet up and share ideas and data. And I think that's very important to do this when you have a system like this, because we need to design it best for the patients. And it's not a novel technology anymore, I'd say, but it's still kind of a new technology, and some are still onboarding. So I think we should for sure help each other to do the best things for the patients.
Yeah, absolutely.
Perfect. There is a comment that the Heart Runner project will be handed over in 2025, but Trinkfonden will pay for the next 4 years until 2027, and that there'll be adverts for the next 6 years until 2030.
Yeah, I see. That's Grete Thomas. She's project lead from Trinkfonden, so she knows everything about this.
Grete.
And hi, Grete, and thank you. She owns a lot and she's one of the primary stakeholders in this, and are responsible for the huge success of the volunteer responder program in Denmark. So yeah.
Perfect. I think there is one more question. Do you know if there are any publications or research on the spread of such systems? In other words, on their dissemination and implementation, where can it be integrated and why? What factors make the implementation of the volunteer responder systems easier or more difficult?
There was sorry, Mass, to interrupt. There was a link in my last slide, which is from a document which I co-wrote with some other clever people from EENA about citizen responders systems. I think maybe it's time to rewrite it, and maybe Mass, I would like to invite you perhaps to have a bit of a rerun of this. But do you know anything else about research publications about the dissemination?
I mean, there are some systematic reviews out there that shows at least some of the major programs and where they are implemented and where, but otherwise I don't think that there are any. I know we're working on an implementation paper from Denmark, but I'm not aware of any other strictly papers focusing strictly or mainly on the implementation of such a program. It's more like data reporting out there. Yeah.
And I promised Alexis and Amy as well that I should add links to the publications that I showed briefly in this publication. I will also add some of the systematic reviews. Maybe I'll ask you, Mass, if I don't have the access to full paper, I'll give you a read. So there will be available publications if you're interested in it. And I think the interest for researching or analyzing the outcomes if you implement a system alerting volunteer responders, that's great. You should not do this without having possibility to look at the data and maybe manipulate it a bit to understand how should you tweak it in your settings. It's super important to understand that how it works, what could you do to change it. So I really urge you to have some kind of research approach for implementation, and that may also be if you don't have the Trig Foundation in your country, perhaps set up a research idea, apply for a grant, and that gives you a maneuverability within the framework of science, where you can actually say, okay, let's try it out. This is a pilot study. Let's see if it actually is accepted. Is it feasible in our settings? And then you can take the next step and apply for more money. But then you need to have control of the data, which is super important, but also very fun.
That's great, David. I don't see any other questions, and I think your last comments actually answered the question I had. I will ask it anyway, maybe as before we close the webinar. So from your experience, what would be your advice to someone who's just starting to set up an AD registry and a volunteer responder program?
Make sure that you know what you're aiming for, and aim for the low-hanging fruits, and to make sure that it actually works. To find out your framework and the possibilities you have, start small and grow big. And I think that maybe relying and like reach out to Mass, ask him questions about what they did, what was the success points, reach out to me. We can answer questions. We're quite friendly, but you need to understand and have the scope of what's accomplishable within your setting, and then just be persistent. We need to power through, and it might be. It's hard sometimes and it's sweaty all the time, but it's also fun. And if you endure, you will achieve great things. But try to identify the problems and see how you can change it. That's my top goal.
Perfect. I don't see any other questions in the chat. So I think there's a lot to take away from this webinar, and I believe there is something that everyone can do for this. And with this, I think it's time to close the webinar. Thank you, David and Mess, for the very informative presentations. And thank you all for participating and being here today. The slides and the recording will be available on the EENA website very soon. That's it. Thank you, and bye, everyone.
Bye. Take care.
Bye.